Good evening to all, and a very warm welcome to the second session of our research methodology series, which we plan to have for the entire year, once a month. And that is going to be, incidentally, the first Friday of every month, but this time we had to make a slight deviation because of the AICOG. So it's going to be on the first Friday of every month. So we are very happy to welcome you to the study designs part 2. Last time it was on observational studies, and today it's going to be on experimental and interventional study designs. So we are very grateful to Dr. Rishikesh Pai, who is a president. He is the Foxy President 22-23 and Secretary General Foxy 2015-17. And he is appreciated and a recipient of many accolades, as one would already know. Very happy to have Dr. Lakshmi Srikhande with us. She is the ICOG chair, and I think no words can actually describe my thanks to her, for having taken up this challenge. Every time I see her at whatever occasion, I keep telling her, "You took up this
Thank
challenge." So she's the national corresponding editor of the Journal of Obs and
yeah,
Gynae of India, national corresponding secretary.
yeah.
So,
Thank
so
you.
many
Thank,
areas of expertise and appreciation. Dr. Lakshmi, thank you so very much for being there with us.
thank you
Uh,
so. Acha, you are introducing everyone. Okay.
yeah, so
Yeah.
the Jogi and Foxy, and then I'll also
Yes.
be, yeah. So Dr. Geeta Balsarkar, she's the editor-in-chief, Journal of Obs and Gynae of India, 2021-23, and she's also very deep into academics, very deeply interested in all aspects of research as well as publication. She has actively participated in various fora. Dr. Khadilkar, she is the professor and head Department of Obs and Gynae, consultant endocrinologist and gynecologist, Bombay Hospital, and she is also I think we are all familiar with her. With her, she's a recognized teacher as well as accomplished person in the area of research methodology. So I now request Dr. Lakshmi Srikhande to please uh, give a welcome note and also take us forward with this session. Uh, Welcome to you,
Yeah.
Dr. Lakshmi.
Thank you. Thank you so much, Dr. Radhika. I am so happy to see that our Foxy ICOG Jogi research methodology web series is going great guns and all because of you, because you have accepted that challenge of coming out with the module every month and bringing up the topmost speakers for to deliver these topics. So thank you so much. And I take this opportunity to welcome all the Foxy office bearers, Rishikesh Pai, Madhuri Patel, and all the ICOG office bearers. I can see Parag Binivale is here. And I also welcome the conveners, the coordinators, all the speakers, chairpersons, and special welcome to Dr. Ambuja, who has logged in because she's very passionate about the research. And I would like to take this opportunity to tell everyone that Foxy ICOG National Conference will be held at Nagpur on 4th and 5th March. We have extended the deadline for paper poster presentations to 31st of January. So please log in to ICOG website to see more details of our conference and try to send in as many papers and posters as possible for this conference. So without wasting much time, I hand over back. I welcome you all once again and I hand over back to Dr. Radhika for further proceedings.
Thank you so much, Dr. Lakshmi. So now it is the introduction of the team. So I need to introduce myself. So I am working as a senior consultant of Gynae in the University College of Medical Sciences and GTB Hospital at Delhi. And I have special interest in evidence-based healthcare and guideline development. And as you can see, there are a few accolades and areas of membership that I have, including the Cochrane collaboration and the Campbell collaboration. And I'm also the LMIC representative of the Guidelines International Network. I have two very strong supports as a part of the organizing committee. I'm very happy to have Dr. Vaishali Kodinayak. She's the professor and head of MER Medical College at Pune. She's a consultant in the Critical Care Obstetrics Ruby Hall Clinic in Pune. And she has also received many many appreciations. She's a fellow in the maternal and fetal medicine at NUS Singapore and examiner to the UG and PG exams. We are also very happy to have with us Dr. Ranjana Sinha. She is the also coordinator for the program. She has many accolades, including she's the chief consultant in the gynae clinic at Patna, former head obs and gynae in the CSSH East Central Railway Patna, and holds very important positions at various professional organizations. So with that, I hand over the floor to Dr. Ranjana. Over to you, Dr. Ranjana, please, to start the session.
Yes, thank you, madam. Good evening, everyone. Paying my gratitude to all the respected dignitaries, it's my privilege to invite the esteemed chairpersons of our first session. The topic is ethical considerations in clinical trials. And to chair this session, I invite Dr. Meena Samant first. Dr. Meena Samant, the recently installed President Patna Obs and Gynae Society, and immediate past chairperson, CRC. Madam, please share the CVs. Should I share?
So you would like me to share the CVs? I will do that.
No, ma'am, just I will, madam, kindly share.
Yeah. Can you see it now?
Yes, ma'am.
Yeah.
Yes, Dr. Meena Samant, she is Senior Consultant at HOD, Gurji Holy Family Hospital, Patna, and President, Patna Obs and Gynae Society. Immediate Chairperson, Foxy Clinical Research Committee, and Past Secretary General, ISOPAP 2018-2021. Welcome. I welcome you, Dr. Meena Samant. Dr. Meena, as all of you know, she is a very meticulous and passionate academician. Next, I invite Dr. Hafizur Rahman. Sir is Additional Professor and HOD, Obs and Gynae at AIMS Kalyani, West Bengal. Sir has also been a former professor and unit head at SMIMS Gangtok. Sir is also a member Governing Council ICOG 2021-23 and founder and current secretary of Gangtok OBGYN Society and recipient of many Foxy awards. Sir, I welcome you. Finally, we have Dr. Archana Kumari, Associate Professor, Curriculum Committee member Skill Lab, and Nodal Officer, MDSR and MNM, RIMS Ranchi. She has the credit of organizing East Zone Yuva Foxy and also Midterm National Conference ISOPAP, a very active member of the Foxy, and also she has been actively involved in quiz committee of Foxy. So I welcome all the three chairpersons to the virtual dais. And before I hand over the mic to them, I would request all the attendees to kindly post their queries in the chat box. So with this, I hand over the session to the chairpersons and request Dr. Meena Samant, ma'am, to kindly introduce the speaker.
Thank you, Dr. Ranjana, and thank you, Dr. And the whole ICOG team for including me in this very informative session that we're going to have today. And it indeed is a pleasure to introduce Dr. Pragya Kumar, although she's been partly introduced already. We know she's the additional professor at AIMS Patna in the Department of Family Medicine and have had the opportunity to work closely with her. We've had some workshops together and they're fantastic. And I think today the viewer is going to enjoy what she has to offer to us. She has served as senior resident in Maulana Azad Medical College, New Delhi, has been the SMO Patna National Polio Surveillance, assistant professor at Narayana Medical College, Sasaram, Bihar, and tutor in PMCH Patna, assistant professor in AIMS Patna, then associate, additional, and I think soon she's going to be professor as well. And she has so many publications. She has so many projects at hand. And I think we're going to enjoy what she has to say. Welcome, Dr. Pragya.
Ma'am, thank you for this wonderful introduction. And as ma'am rightly said, that we have been working closely for many projects. Like I was first introduced in the qualitative research methods when ma'am as introduced by Dr. Ranjana, that she's very enthusiastic and very like at this age also she has that keen to learn new things. So that's very inspiring for all of us, ma'am. Thank you so much. And without any further delay, honorable respected chairperson and all my senior professors and my colleague and all the participants, I'm starting sharing my screen. So the topic which has been given to me, that's the ethical consideration in clinical trials. So now coming to ethics in clinical trial. So there are two terms involved in this topic. First is the ethics and then is the clinical trial. So we all do clinical trial as a part of, as a clinician. So we have got so many responsibility. We have got patient care, we have to do the research, and then we have to do the publication as well. So this ethics has got three parts. There is a medical ethics when we are practicing that simultaneously, because we have got a dual role. So we are a researcher. So we have got a research ethics. And then third is the publication. So that's the publication ethics. So I'll be covering briefly all these three ethics in my talk. So now how to define ethics? So as this word suggests, so what is wrong or what is right in our behavior, whether we are doing our medical practice or as a researcher or we are doing a publication. So whatever is right or wrong, that is known as ethics. Now, there is a term known as the clinical trial. So what is a clinical trial? So whenever we are studying any new test or any new drug or any new intervention, where we are going to see the effect on the human health outcome, that is known as the clinical trial. So if you have to decide whether your study is a clinical trial or not, you should ask first 4 basic questions. So this is a checklist thing. So the first question which you should ask, that does the study involve human participants? So we all do most of us do our study on human participants. So yes, that is going to be there always. Then second is, are the participants prospectively assigned to an intervention? So whomsoever we are recruiting, are we going to assign any intervention to them? And the third part is this study designed to evaluate the effect of intervention to the participant? Obviously, that is going to be there. And then is the effect being evaluated as a health-related biomedical intervention, or even if it is not, then even it is a behavioral intervention, then also it will be like a clinical trial. So if the answer to all those 4 questions is yes, then the study would definitely be considered as a clinical trial. Now, just see this question, because I don't think there's a Zoom poll over here. So like if I ask this question to the participant, that if the answer to all these 4 questions are yes, but my study involved only healthy participant, is it still going to be a clinical trial? So yes, the answer would be yes. Even if you are involving healthy individual, they are not the patients or they are not the sufferer, then also it will be a clinical trial. If the answer to all the 4 questions are going to be, okay, Dr. Archana is, I think, answering in the Zoom poll, because I can see the response. Okay, thank you, ma'am. And then if the next question is like, if my answer to all these 4 questions are yes, but my study does not have a comparison group, it's only the study group which I have, is it still going to be a clinical trial? Then what is the answer? If then obviously the answer is yes. Even if there is no intervention group, the answer will be yes. Thank you, Ambuja. Then coming to the third question, if the answer to all my 4 questions are yes, but my study is not involving any drug or any operation or any surgery, so it is only a behavioral intervention, maybe counseling, like in one group you are doing a family planning council for the adoption of a particular service, and in the other group you are not doing it. So will it still be a clinical trial? Yes. So very right. So you all are right, Vandana and Dr. Archana and all the participants. So another question. My study intended solely to refine treatment. Is it still a clinical trial? Means there is already a treatment, maybe a surgery, but I just doing some minor modifications over that. Is it still be called as a clinical trial?
Yes.
So actually, if you go by the definition, then if you are just refining some minor things, then we don't consider it as a part of the clinical trial. That is the NIH definition. Then again, if my study involves the secondary research with biological specimen or health information, is it still a clinical trial? Like I'm doing the secondary data analysis. I already have the data and I already have the health information, or maybe some specimen on which I have taken the approval of the ethical committee. Still, can it be called as a clinical trial? So yes, answer will be no. So thank you for the responses. And now coming to some historical perspective of this, how this this has evolved, this all ethics part of this research, how it has got evolved. So coming to historical perspective, if you have all must have read during your history chapters that Nazis, they did a lot of experiment on the during the World War II, just to benefit the German Air Force or just to benefit the German force. So they did a seawater experiment where they just exposed all those people, they kept them fasting for so long, and then they offered the seawater to them whether the seawater is drinkable or not. And then again, they did a freezing experiment where they have exposed the naked people to very less temperature for 3 hours, putting them in ice water, and then giving them the heating mechanism just to revive them. So these experiment, again, there was a high altitude experiment, whether the study they have like put the that limited the human endurance when the subjects, they were put in low pressure chamber at 68,000 feet. Again, there was a mustard gas experiment to study the effective treatment of wound and mustard gas, and it was deliberately inflicted over the wound. So all these, there are many more similar experiments which was conducted by 23 physicians during the World War II in Nazi's camp. And they all must have taken that do not harm principle of the Hippocratic Oath. Because if you just recall, I talked that there are, if for a physician or for a clinician, simultaneously doing in research activity, we have got three roles. So we have got a role of a clinician, we have got a role of a researcher, and then again, we are going to publish also. So as a role of, if you think the medical ethics, so we all know that there are 6 principles of medical ethics, like beneficence, that means we should do some benefits to them. Non-maleficence, that means first we should do not do any harm. And then autonomy, we should respect patient autonomy, and then dignity of the patient, and then justice towards them. All those things we all know regarding that. But that was not practiced here. They were sentenced in the Nuremberg trial, and that has led to the formation of Nuremberg Code. So that was the first event when the mankind, they have realized that they cannot do experiment like this. And this process of informed consent, which we take these days, although we will also discuss how we take and what are those limitations, or what we do just to benefit our research in case of an informed consent. Now, there was another study, which was the Tuskegee syphilis study, where the American Medical Research Project they conducted. It was conducted by the US Public Health Service, and they examined the natural course of the untreated syphilis in the African American men. And whenever they have to, all the developed country, they have to do some research, they will always come to the less developed country, maybe Africa, or maybe Black people, maybe some part of India, Bangladesh, and all those countries which are still developing, and they don't have a say. Maybe they don't have those many rules and regulations to abide. So that was also followed there, and they were having 399 men who were already in the late stages of syphilis. And although there was a treatment available for the syphilis, but the treatment was not used. Later, the government, they have apologized for the study, and they said that it should not be done. It was a violation of the human rights, and that study should not have been done. Again, there was a study in the India cervical cancer study where this was also published in BMJ in 2014, and there was a 3 clinical trial where they were screening the cervical cancer in India. It has provoked controversy and also showed that they were all the 254 women in the unscreened group, they had died of the disease. Again, there was another study. These are the example of Indian context where there was an anti-malaria compound study, and it was also a multi-country study where the thousands of Indian and Bangladeshi women, they were given the anti-malarial compound mepacrine that was used as a part of the female sterilization, and where it causes the side effect like inflammation in scar tissue, and the fallopian tube, it was blocked completely. And this trial demonstrate the differing ethical standards which has applied to the different country setting like India and Bangladesh. The Supreme Court banned the use and sale of this drug, but still it was continued to be there in the rural Bengal up till 5 years after that. There was another trial like M4N and G4N trial where these drugs were used. This was conducted in the Thiruvananthapuram in the government-run regional cancer center. Although the other people were also involved, but the ethical clearance, it was not shown properly. And these are the examples showing not following a research ethics in the trial. So now there are few case study for all of you, and you have to identify first, our eyes should be able to identify in our brain too, because we all of us know what is right or wrong. But because of these petty gain, and these gains can be anything. So because of that, we are not able to see. Like we know that alcohol is not good for health, but in spite of that, we do so many things which are not good in spite of knowing that. So there is a difference between the knowledge and practice. Similar thing is existing for the ethics. We all know in our core issues, in our core heart, that what is right or what is wrong. The thing is to identify and to act on that. So let's see in this example, all of you, I'll go through this briefly, that it's a case study that Raju has cancer and the traditional treatment has been only intermittently successful. He then recruited to participate in a randomized single-blinded. So just see, it is a single-blinded. So the researcher is knowing in which arm the person is. So it was a placebo controlled. So the other arm was placebo by his oncologist, Dr. Ramesh. It's just a hypothetical case study. The new drug that is beneficial to the patient with such kind of cancer that the Raju has, and the trial is set to there for 1 year. And after 6 months of the study, Raju realized that he's not experiencing any signs of improvement. He may, in fact, he's getting worse. So Dr. Ramesh continues to receive reports, and he's saying that, the research is going good and there is a benefit in both the arms. And then I can see that after the examination, the Raju, he asked Dr. Ramesh if he's in the treatment arm or if he's in the placebo arm. So Raju requests that if he is in placebo arm, Dr. Ramesh switch him to the treatment arm so that he can receive the possible benefits of the new treatment. So Dr. Ramesh knows that Raju is in placebo arm. So what is the ethical issue here? So basically, ethical issue, if there is a treatment already available, the guidelines are that you should not have a placebo arm. You should be giving the standard treatment to an arm, then only you can have the other new treatment with the other arm. Now coming to the second ethical issue here. So one vaccine, which is the RRV-TB vaccine, it was licensed in US after RCT in developed countries, and it has showed that 60% efficacy in preventing diarrhea. However, shortly after this FDA approval, the vaccine was withdrawn from the US market because of the cluster of that cases of interception, which was a risk in 1 in 10,000. So a similar RCT was also being planned in the developing country at that time. So should the trial be allowed or to proceed? But it was seen that the diarrhea was not that common problem in the US, but it was a very prevalent problem in the developing country, and the burden showed that 6 lakh kids, they died of the rotavirus diarrhea in the developing country in spite of ORS. So now there is an ethical dilemma here. So should you allow to conduct or ongoing trial, or should you be stopping this trial? So again, these problems are existing there, where you will see that there are some ethical dilemmas. So you have to weigh the benefit versus the risk in these cases, and then you can take the decision. These days we have a committee, most of the time in the clinical trial we'll discuss about that, who takes this decision of whether to allow the trial to conduct or you should stop the trial in between. So now, what are the ethical problems in clinical research? So the first thing which I discussed, this is one problem, which is the dual hat problem. The physician is the investigator itself, so he has to practice the medical ethics as well as he has to do the investigation, that research ethics also. Again, there are ethics involved in the randomization and blinding. We will discuss each of these issues separately. I'm just enumerating it right now. And then there are ethical issues with the preliminary data. What to do if you are doing some interim analysis, and what to report, what not to report, and then ethical use of placebo. So coming to this dual hat problem, so these days we know that as a clinician, like if you are working set up in any of the medical colleges or any of the research center, you are seeing patients also. So patient well-being should be the physician's primary concern. And but however, if you are having the role of a researcher also, then or you are trying to you are testing some drug or some surgery or any other intervention, then you have got additional responsibility, and at many time that you may be landing up in conflict with providing a good patient care. So like in that case, what you should be doing? So it's ideally recommended, like for example, if I am the head of the department and if I am the clinician, so I am asking people, they are coming to me for consultation and I'm treating them, and simultaneously I'm enrolling them for the research. So they don't have, because there are power issues here. So if you ask them to be in the trial, they cannot deny, because they'll think that then they will not get the treatment for which they have come here. So it is recommended that you should have some other place for that, some other room, or you can have a team where they do that work and you see the consultation part, or that role should be different at that point of time, even if you are doing the monitoring overall. Again, then you should understand the difference between the ethics of clinical research and ethics of medical practice. In many times, while taking the informed consent for surgeries also, or for this, we all have seen that we don't read the whole part of the consent process. We just, it's implied that they are illiterate people and they are not going to understand. So we don't read the whole thing, and we just do like reading the initial few lines or interpreting, and many times we don't even give them the copy of that participant information sheet. We'll discuss those issues. So that dilemma is always there with us. We have like this, if we'll tell everything to them, we are going to lose this case, or this person is not going to come into our trial. So that's there. So if you have to see like between the medical practice, what is the difference, the purpose in case it is a medical care and the research. So if you see the purpose of this medical care, then the purpose of this medical care is basically the individualized care. So you are giving the consultation, so you are concerned about the individual patient, and your purpose is to give treatment to that patient. As a researcher, what is your role? As a researcher, you want to add something to that already existing medical knowledge, and you want to contribute to that. So that's the purpose. So method, what are we adopting as a method? So that's the routine care which you are doing as a medical care. And in research, what you do the randomization, maybe if it's a clinical trial, we do the blinding, we do the restrictive doses, like we do the trial with a different set of doses, and we do the tests to measure the study outcome. Now coming to the justification of risk. So if you see the justification of risk, usually, like apart from few complications of surgery, which we, in that case also, we do inform them and we do take the consent. But apart from that, it is usually going to be doing the benefit to the patient because that's the standard therapy which is available. We are not going to test something new. Whereas in case of a research, you are not very sure regard excuse me. So you are not very sure regarding this benefits which you are going to give to the society. So basically, you anticipate that whatever knowledge will be gained, that is going to be beneficial not to that particular patient, but to the scientific community. Now, what is the ethics involved in the randomization and blinding? So we all know what is a randomization and what is a blinding. So basically in randomization, what do we do? The patient comes to us and we have got these days we follow the computer generated randomization. So the decision, ideally as a clinician, what do? We decide for the patient and maybe we give them the options if there are more than one options available, but we decide for the patient. But in case of a trial, what do? It's the computer who is deciding for the treatment. So that judgment is not involved. Maybe as a researcher, for the validity of the research, it is good that we are doing the randomization and blinding. But the preferences and if you see the autonomy of the patient, that is many times it is violated in this case. And the concern for the subject safety and well-being, that is also, it's not if there is an adverse event, so and if there is a blinding, so we know that even the investigator is blinded, and if some side effect occurs or if there is a serious adverse event, whether that adverse event is due to that particular drug, new drug which we are giving, or is it because of some other thing? So we are always in dilemma that we don't know. And then how will we, monitor that? Maybe monitoring we can do that, but how to manage, and is it ethical that they are undergoing to this treatment, and in spite of that, they are having the side effect. And then another thing like surgery, a lot of trial here also in our institute, they conduct a lot of trials, and we subject the individual towards the treatment options. And when we say that the patient will be blind, I'm not sure that this thing, the patients are informed correctly regarding their choices, because most of the time, although we say that we are going to take informed consent, but we take their consent as an implied, because we think that if they will not be a part of the surgery, we are not going to do the surgery. If they are not going to say yes to this procedure, we are not going to give them any other treatment options. So that's the general attitude. I'm not saying that that's the universal thing, but many of the surgeons, especially, or the people who are involved on those clinical trials, they have this say that, the patient, how will the patient will say no to this trial? And if we say that kindly read all this consent process in a way it should be done, then they say they are very scared. Ma'am, then to they will refuse. Nobody is going to come in our trial. If we tell them that you can have these many side effects, or because if there's a risk of death, you will always say that there is a risk of death also. In vaccine trial also, we have seen that many times we don't convey them the whole thing. And we say all good things, no, you will get those benefit, and we try to lure them with these days. So monetary thing is also there. If you participate, you will get so much of money. And the people are poor and they don't have they'll think that they are something good, and they should come. And if it's a reputed institute like tertiary care center like AIMS, or probably the higher setup, then they feel privileged. So that's the thing where we I don't know what should be our role. So that randomization thing and the blinding may have some problem in case there is some serious side effect. So now there are some rules, like when you can break the randomization, or when you can break this blinding. Because blinding also, although many trials are double blind, but there is a data safety monitoring board, and they take this decision, like when can they stop the trial, or when can they inform the participants. So now there is ethical issues with the preliminary data. and stopping the trial early. So like if you are conducting any trial, and if you are doing some interim analysis, because in all the trials, like in case of this COVID vaccine trial, which happened here at our institute, and maybe many trials, vaccine trials. So interim analysis is there, and there you see like any serious adverse event. And again, you weigh that one of the therapies, because there were two arms. So whether that vaccine was effective or not, or in case of drugs also, uh, yes, in case of a drugs also, this therapy, which therapy seems to be effective, and one of the therapies seems to be safer or serious adverse event, and it seems to be associated with one therapy. So whether you should use this as a casual this thing, or whether you should report it or not, or if there is no emerging trend is yes, if there's no emerging trend, then demonstration should you be saying that to the participant. So in all these cases, there in this there's example of this streptokinase, yes, that this was stopped, which was for the acute myocardial infarction, and primary endpoint, which was the mortality at 5 weeks. So it was seen that definitely the streptokinase, it was superior before the trial was concluded. So then the trial was stopped prematurely, like Ambuja. Dr. Ambuja is also writing that the WHI trial stopped prematurely. Yes, so the trial was stopped prematurely, and it was taken a decision that the streptokinase would be given to the placebo group also, because it was clearly seen to be superior during the interim analysis also. So this Nuremberg code, it said that the scientist in charge, he should be prepared to terminate the experiment at any stage. And because he has probably the cause to believe in the exercise of the good faith, superior skill, and careful judgment required of him, that is a continuation of the experiment, is likely to result in injury, disability, or death to the experimental subject. Again, the Declaration of Helsinki 2013, it also said that when the risks are found to outweigh the potential benefit, or when there is a conclusive proof that the definitive outcome has come, then physicians should assess whether they should continue, modify, or immediately stop the treatment. So now what should we do after the interim analysis? So there are three possibilities. There is a possibility of full disclosure, non-disclosure, or incomplete disclosure. So these days, generally the interim analysis results, they are not shared to the participant. But for that, we take a consent. Like in consent process, you might have seen that you say that the result of the interim analysis will not be disclosed to the participant, because you are not sure. In case like you have just started the trial, and if one person has died, maybe because of, remember during the COVID trial also, there was a lot of hue and cry regarding that that person was given the COVID vaccine and then he died immediately. So all these things, many times they negatively affect the trial, which is not a true thing, because if you are doing something in the community, and if some rumor, because the media and the other people, they don't know the reality of that death or whatever the serious adverse event has happened. Even with the pentavalent vaccine, there was a lot of rumor that it is causing the SIDS, that is the sudden infant death syndrome in the baby. So these days, those things are also, they, although in the long run, you will see that it is going to cause the benefit, but for that, you have to wait till that time. So that full disclosure prematurely, it is not often warranted, because we don't know the exact cause. So that consent we take from the participant. Now there is something known as the Data Monitoring and Safety Board. What is this? So Data Monitoring and Safety Board, it's a committee of people. It is an independent data monitoring committee, which has to be established by the sponsor to assess at regular interval the process of the clinical trial, and then the safety of the data. Then again, it says that the clinical efficacies endpoints. What will be the endpoints of the clinical efficacies? And it has to recommend finally to the sponsor whether to continue or to stop the trial. So now coming to the ethical use of placebo. So we said that placebo, these days we should not use the placebo, because placebo is basically it deprived the individual of the treatment that they may have gotten. So the experimental treatment without a proof of superiority, that may cause at harms, or it can be useless. So placebo should only be used when there is no standard treatment or no effective treatment against that particular. Am I? No, mine is there, I guess.
Yeah, we can see your slides, and it's only
Yeah,
that you
sorry.
need to. Yeah,
I thought that that there was some issue with the network. I'm
no,
sorry.
we can see that. Please carry on.
Okay, thank you. So now we have seen, so that I was talking that it should only be used, that placebo, when there are no other standard treatment available. So we have seen like the medical ethics and the ethics involved in the research, like all those principles. I'm not going into the detail, just a very brief for this thing. Now coming to something known as the publication ethics, because this research also involves the publication. Obviously, if you have done something, you will definitely will like to do the publication. So before that, there are some, we do some unethical practice in research, like we do unethical research. So unethical research is even worse than no research at all. We do fabrication, like we make up the data and the result. And again, we do the falsification, like we manipulate the data. Many times we'll see like people coming to us like, please change something so that it should become significant. So we all are in the favor of giving positive result always, because we think that negative result has got no value. And all our study, especially during the thesis work, we experience this problem a lot. So they say that if nothing has come up, my study is not going to be published. So that is also one of the bias which exists in the publication with the journals, that they don't support all those findings which are of a negative finding. So these things are there. And then again, because we see a lot of guideline in the NMC, there is a pressure to publish. So people who don't want to do research, they have to do the research. There are so many ghost journals are there because it leads to their career prospects. There are inappropriate personal ambitions. Then there is greed are there. So because of all those things, are we taking the participation from the people truly as a voluntary participant? Are we doing an informed consent, or is it just a proxy consent? And are their privacy being protected by us? And what is the place where we are doing these survey? And the length of the questionnaire also, we have got so many big questionnaires and it is taking so much of time. And you can think about a person, even we refuse to give even 5 minutes time to forget about 5 minutes, 2 minutes time, but we don't value that.
Last 1 minute, last couple of minutes.
Time is important. So there are few ethical issues in publication, and all these ethical issues, the very serious ethical issue is the plagiarism. So plagiarism is about when you are stealing something, copying something, then it will lead to the plagiarism, and there are penalty for plagiarism. So this UGC guideline says that if there is a plagiarism by faculty up till 10%, and to the student, then there is a no penalty, but up till 10 to 40%, you can see there could be revision. If it is more than 60% of plagiarism is there, it may lead to the cancellation of registration also. So that's the thing. And I guess I would like to end my talk here with this summarization, that as a researcher and as a clinician, we do have to play many role, but again, it has to be done using the what is wrong, what is right in our this thing. And again, there are many guidelines, as Dr. Radhika was also saying, like video recording of those consent process and everything. We all know that. But again, we know from the deep heart and from the core of the heart, like those things will be there. But there are people who can defy those processes also. So it's the single person or the researcher whose ethics will guide the ethics and will control the ethics of everybody in the team. Because if the ethics is not coming from the top, definitely it will not percolate to the bottom also. Thank you so much. And I would like to thank the Foxy and Dr. Ranjana and everyone. Thank you so much.
Thank you. Good evening, everyone. Thank you, Dr. Pragya, for your excellent presentation. I think you have explained everything, details of ethics in different aspects and different fields. It was a very nice and elaboration and presentation, as ethics is very important to maintain the integrity of the research as well as the safety of the patients. So as clinicians, as you have very nicely told, that we need to avoid unethical research, fabrication, and falsification. That's very much
Stop your
important.
screen sharing.
Yeah. So it has been, the talk is was very important. It's very important as it's very explanatory for understanding of all. So it was an excellent presentation. Thank you for your such contribution and having an excellent presentation ethics in clinical research. Actually, everyone have been very benefited with this, and we have increased our understanding for betterment of our patients. Thank you so much.
Yes, Dr. Archana, would you like to say something?
Yeah, thank you, Ranjana and Radhika ma'am, for giving me this opportunity. And I would just like to congratulate Dr. Pragya for an excellent presentation. And I would like to reinforce her views that as a clinician, as a researcher, and while we are publishing, and at all these three roles, we have to look after the ethical issues. And the process of informed consent is, of course, very important. It is a dynamic process, and we often, as he had already explained, that we often tend to overlook. We don't want to read the whole participant information sheet to the patient, taking into account that trial will not, that there will be problem of participant recruitment. But we have to look into all the ethical issues, especially the patient's right to autonomy, justice, beneficence, and non-maleficence. Thank you.
So, thank you, Dr. Pragya, and thank you, Dr. Meena Samant, Dr. Hafiz, and Dr. Archana. I think Dr. Hiralal Konar, sir, had raised his hand during the talk. Sir, do you want to say something? It is our privilege that you are here with us. I think sir is not listening.
Can't see him.
Yes, and I would like, Ambuja ma'am, would you like to say something, ma'am, add to this? Since we have no questions, we'd like some inputs from the seniors.
Thank you very much. It's an excellent presentation, Pragya, and I appreciate Lakshmi for arranging such a good program. And actually, we were in need of plagiarism, how it is being done, which is not covered completely. I think we should take up this in a next class. That is really in need of correcting the papers or anything going through that one. If it is done, it will be good. Otherwise, it's an excellent presentation with all the examples. Thank you very much.
Incidentally, ma'am, we do plan to have a session on critical appraisal of literature and plagiarism. Ambuja ma'am, in response to your suggestion.
Thank you. Thank you.
Yeah.
So let us move on to our next session, that is on RCTs, and our esteemed speaker is Dr. Prabhadeep Kaur. It is my pleasure to invite our esteemed chairpersons. First, I would like to invite Dr. Sashwati Sanyal Chaudhary. Ma'am is Professor OBGYN at Guwahati Medical College, past President GOGS, and had been Chairperson Medical Education Committee 2013-15. Welcome, ma'am. And then we have Dr. Abha Rani Sinha. Ma'am is Professor and Head OBGYN, SKMCH Muzaffarpur. Madam is also ICOG Governing Council Member 2021-22, past President Patna Ops and Gynae Society, and currently a National Corresponding Editor, Jogi 2. Welcome, ma'am. And finally, we have the Curator of highly acclaimed AICOG 2023 Kolkata Scientific Chair, Dr. Ashish Mukhopadhyay. Sir is Principal and Professor at CSS College of OBGYN, Kolkata. Sir has been Vice President FOXY 2016-17 and also past President Bengal Ops and Gynae Society. Welcome, sir. And
Ranjana, the slides have to
oh,
move.
sorry,
Yeah,
madam, sorry. We have our three chairpersons, Dr. Sashwati Sanyal ma'am, Dr. Abha Rani Sinha ma'am, and Dr. Ashish. I hand over the mic to the three chairpersons, and request to conduct the session.
Okay, may I have this thing for yeah.
Yes, yes, ma'am.
So our first speaker is next speaker is Dr. Pradeep Kaur. She's the scientist and head division of non-communicable disease ICMR, National Institute of Epidemiology, Chennai. A physician and public health professional involved in research, teaching, and implementation science for scaling evidence-based public health interventions and policies in the healthcare system. Dual training in internal medicine and field epidemiology. Okay, that's a really, really interesting epidemiology. I know how important is this in the research. Member of WHO Global Cervical Cancer Elimination Expert Group since 2019. Then she's the PI of Indian Hypertension Control Initiative, which recently won UN Interagency Task Force Award 2017 onwards. Congratulations for that. She's the faculty of MPH and course coordinator for AFI-TP NCD fellowships, and she has more than 80 publications in peer-reviewed journal. I think after this interesting talk on Pragya, and rather you get confused when you talk about ethics, which one is right, which one is wrong. It's really, because I'm a member of the ethical committee, I know sometimes it is so difficult to decide whether this should be ethical or not, especially during the COVID situation. There are lots of studies whether we had to, because it being one of the institute in the Assam, in our state, we had to do a lot of intervention, so many things, including plasma and all. But, at that certain point of time, I think you have those problems regarding the ethics. So if you do not have anything, sometimes those issues always comes. So I ask Dr. Pradeep to talk on your topic. Now the podium is yours.
Thank you very much for the kind introduction. And I really would like to thank the organizer for this unique opportunity. It's very rare that we get to interact with other specialties, and that's where we learn a lot. So I think without any further delay, I will get started with the session. So I will be talking about randomized control trials, and my focus would be on the design and the protocol writing, because that was how it was given to me. So as you all, I think you had previous session on cross-sectional studies, and this is sort of a continuation of that, because we have many study designs that we use in research, and the commonest being cross-sectional surveys. However, in clinical research, quite a few people use randomized control trials. So this is just to give you an overview of what is the level of evidence that we get from different types of studies. I'm sure many of you have seen it before. So this is what we call as how much value is given to an evidence, depending on what kind of study that evidence comes from. So the highest level is meta-analysis of RCT, means if there's an intervention and many trials have been done on that intervention, and we pool the data together and then come to know, okay, fine, does it really work? So that's the best case scenario. And the next best case scenario is that you have at least one randomized control trial which showed that the intervention works. So I'll not spend too much time, but as you can see here, many of you quite often hear that there are expert opinions and then there are surveys. So in terms of introducing a new intervention, all of them have very, very low ranking in terms of how much we can rely on that evidence. So just to give an overview where RCT fits in. So there are two kinds of study designs in epidemiology. One is observational study designs, and then we have experimental study designs. And in the observational studies, the investigator is not manipulating anything. Whatever is there, we are just observing it and trying to interpret it. And in this observational study design, I think you had the session last time, you have the commonest thing we do is the cross-sectional surveys. And within observational study, you can also do analytical study, for which you have the two possible designs, which is cohort and case control. However, today we will be focusing on the experimental study design, wherein we are trying to change something. So there is there is some manipulation by the investigator, and we are not just observing the situation. So I think first and foremost, whenever you think about a study, please put this framework and think, which of these designs do I really need to look at? And as it's there in the program, towards the end of my session, I will be walking you through a few examples as well. So what is RCT? I think my previous speaker has really made my life easy. So I will not spend too much time, but I'll just run through one or two broad definitions. So it's a planned experiment which is designed to assess efficacy of a treatment in humans by comparing the outcomes. So there are keywords here. So you're comparing. So RCT always has a comparison group, and there is an outcome. So you're comparing the outcome, and you're doing it in a group of patients which are treated with a particular kind of test treatment, which is the new intervention that you're trying to introduce into your practice and system, compared to whatever is the control treatment. Now, quite often the control treatment could be what we call as a usual care, means whatever is already being done in that setting, or it could also be sometimes placebo. But as you know, quite often we are not able to do placebo anymore due to ethical reasons, but it's usually the usual care or the treatment that you are normally using before you came to know about this new intervention. And in every RCT, patients are enrolled and then given intervention over a period of time, and then you measure the outcome. So this is another very similar definition from NIH, which says it's a scientific research activity which is undertaken prospectively. So this is most important. RCT is always prospective. It's a forward-looking trial. I mean, clinical trials always forward-looking. And you want to look at the value or effect of, it's not just for a drug. It could be for a surgical treatment. It could be for a device. It could be for a behavioral intervention, anything. So for any of this, you can do RCT. And it's prospective, and some sort of intervention is taking place. Now, very important to understand, like today, what we are talking is basically phase 3 trial, because that's what you do as a clinician in the clinical setting. But actually, there are 4 phases of clinical trials. The phase 1 is just to know whether it's a safe intervention at all. So it's called, the focus is on the safety and to know what kind of dose really works. And this kind of phase 1 trials are done in a very small group of 15 to 50 patients. The phase 2 trial focuses on effectiveness and side effects, and it is given in a slightly larger number of patients because you also want to know whether there are any side effects. So the sample size is a little bit more. So phase 3 trial is the main trial, and that's what today we are mostly talking about, phase 3 trial, wherein you are comparing a new treatment against an existing treatment, and the sample size may be in hundreds or thousands or lakhs, but it's definitely much bigger than phase 1 and phase 2. Now, quite often you may also get some information from phase 4 trials. I think you might have heard that, some drugs after being tested in phase 3 trial are actually launched into the market and then withdrawn later. This is usually from the phase 4 trial, which is basically post-marketing surveillance. So once the drug is put in the practice, you still continue to monitor. And because always when the sample size becomes large, some of the rare side effects emerge, which we could not see in the phase 3. And with those, there may be a need to actually withdraw the agent. So now we will come to, why do we do RCTs? This is the best method to control the selection bias, to make sure that both the groups are equally comparable and you are not selectively choosing one kind over the other. And it also helps us in blinding, and I'll talk a little bit more about it later. And you can apply several statistical methods to draw conclusions and interpret the whole experiment. And you have the advantage of a cohort study because it's a forward-looking. Now, the disadvantage is that it's quite complex. As you know, the RCTs are expensive, they are big, you need money to do these clinical trials. And especially if your outcome is occurring in very, very small number of patients, then the sample size becomes so large and it can be very difficult in such settings to even do the trial. They may not be representative because we end up excluding certain groups. Like for instance, as gynecologists, what may be relevant to you is a lot of drug trials in medicine exclude pregnant women. And hence, in the end, we don't know whether that particular drug can be used for pregnant women. So that way, the representativeness may be an issue. And of course, you heard a lot of good stuff about ethical challenges. And I think I really enjoyed the talk. So I won't talk about that, but I think most of the issues were covered. And very difficult, it may seem very difficult, although you can acquire skills over time, but definitely it requires some level of experience in research. So when you're doing a clinical trial, first and foremost, you need to define what is the purpose of the trial. Then you design the trial, you write a detailed protocol, and we will be going through what should the protocol have. Then you conduct the trial. You need to know when to stop. So I think there was brief discussion about some trial which was stopped. So there are situations, and there are in your protocol, you also need to clearly spell out what are the conditions under which trial might be stopped. And then you need to do data analysis, draw conclusions, and publish. So these are the steps of clinical trial. And I think, I'm sure many of you have heard of this, what is called as GCP guidelines, Good Clinical Practice Guidelines. So these are the international ethical and scientific standard, which are minimum requirement, which you have to follow for the development, conduct, performance, monitoring, auditing, recording, analysis, and reporting of the trial. And now there are many organizations which conduct training, GCP training for the investigators. So it is advisable that if you want to become an investigator for clinical trials, you undergo GCP training. Now we will be going through the steps of the protocol. So these are the 13 subheadings which I have just outlined here, just to make it easy for us to understand, because I understand many of you may be teaching, or if you're a PG, you might be writing a protocol, and it's really important that you have a structure. And for you to have a structure, you should know what will be the subheadings under which I have to write. So of course, we always begin with background and methods, and these are all the sections that I will be now going through one by one. So first and foremost, objective. So what is an objective of a randomized control trial? Anybody wants to put in the chat box any experience with one objective? Any objective of a clinical trial that you have been part of? You can put it in the chat box if anything comes to your mind. So basically, a clinical trial objective is about efficacy. The efficacy of the intervention, the group which the intervention could be a drug, it could be a behavioral intervention, whatever you're trying to study. What you want to know is it better than whatever was the usual care or the control group? So efficacy is the key word. So primary objective, if there's one word you need to remember, that is efficacy. So what happens is, like in several observational studies, we can study effectiveness, but what you study in RCT is the efficacy. So quite often there is a primary objective and there can be one or more secondary objectives. Primary objective need to be defined very carefully, because you need to calculate your sample size for the primary objective. And you may not be able to calculate your sample size for all the objectives. It could mean that, the study may become totally out of hand. So what we do in the secondary objective is we could either have another secondary outcome, for which again, you can look at the efficacy, or you can do what is called as a subgroup analysis. Like you could say, how did that particular drug work? Let's say by age group, by if you are doing it for, let's say, during pregnancy period, it could be like you could stratify by which period of pregnancy and so on. Subgroup means just looking at the same outcome, but different groups which were included in the study, or different characteristics of the study population, how it worked in those various groups. The next thing what you write down in your section is your study design. And here, the most common RCT design is 2 parallel groups, means you have 1 control group and 1 intervention group. That is the most common design, but that's not the only design. There are many other designs in RCTs. Like you could have multiple arms. There are trials with 3 arms, 4 arms, and so on. There are crossover trials wherein the intervention is given to one group and then the other group is given intervention in the second half of the trial. There are cluster randomized control trial, very common in public health. So in settings where you cannot do individual randomization, you may randomize by communities, by villages, by facilities. And those kind of cluster randomized trials are helpful in situation where you don't want, where it's very difficult for you to do blinding and those kind of interventions are done at a large scale. So for example, if you're doing counseling and things like that, so usually cluster randomized trials are undertaken for that. Again, there are 2 types of trials, superiority trial or non-inferiority trial. So superiority trial means where you know that you are assuming that your intervention will be better than the control group. And non-inferiority or equivalence trial means that it's equal, may or may not be better. Now coming to most important, I think this is the critical thing. Who gets into your study? What is the eligibility criteria of your study participants? And how are you going to recruit those participants? Are you recruiting them from community? Are you recruiting them from your outpatient department, inpatient department, or wherever? So you need to write down what all places you will do recruitment, who will do the recruitment, how will you talk to the patient. So I'm just going back to the previous speaker's concern. You know, sometimes people say, oh no, if I give too much information, the patient may not agree to participate. No, that's not acceptable. When you are recruiting your participant, you need to make sure that all the information is given. And then inclusion and exclusion criteria. You need to clearly define who gets in. And even though certain people may have certain characteristics that you want, but do you need to exclude certain criteria based on certain criteria? Next section would talk about study setting and the sites. Setting means, is it being done in a clinical setting? Is it done in a primary care, secondary care, tertiary care setting? Or is it done at the community level? So there are trials which are done at the household level where the participants are recruited at the household level. You need to describe the setting and the context in which this particular trial is taking place. For instance, a public sector tertiary care hospital is very different from a corporate hospital. So you need to define the context, what kind of socioeconomic group comes into that setting, giving a good understanding to whoever is peer reviewing your proposal as to what kind of people are likely to be included into this trial. The next comes whether it's a single site or multi-site. Quite often, depending on what kind of condition you want to study, it may not be possible for you to recruit all the participants in your setting because it may take very long time. And in such situation, you may decide to add more sites. Now, next is the most important thing. This is exactly what you are trying to give. You're trying to do an intervention, and hence you need to describe that intervention. So you need to say what will be that intervention. If it's a drug, you need to say the drug name, the dose, how it will be given. Is it oral? Is it IV? Is it IM? When will it be given? How many times it will be given? Are you going to give only the one dose, or you are going to titrate the dose over a period of time? And you also need to mention, will you stop giving drug? Let's say you started giving the drug and then patient develops some side effect or allergy or something like that. Will you stop it? If it's a surgical procedure, because quite often, I think in OG, you may be doing trials to compare certain kind of surgical procedures. You need to define the procedure in detail, all the steps that you will be carrying out. If you're doing a diagnostic test, then you need to describe in detail what the diagnostic test is. Now coming to the outcomes. Whenever you're writing, as I said earlier, your objective, outcome, sample size, they're all connected. So you need to make sure you know what exactly you want to measure. So primary outcome is very important because it's used for the sample size calculation. You need to mention all the definitions, the measurements, and try to use standard definition wherever possible, if it is available from any societies or any other scales and so on. But you can also have some secondary outcome from the definition. Are there any questions at this point? Because maybe I'm going a little fast.
Yeah, Dr. Pradeep, you had posted, you had asked for some examples and people have posted.
Okay, good.
Uh,
I'll look at that. If you can give me just 1 minute, I need to grab some water. Just
Certainly you can do that.
Yeah, sure.
So in the meantime, I think it's a good idea for us also to understand that there is something, it's different, the two terms, efficacy and effectiveness. So I think it's extremely important because when we do it in the controlled settings and when we do it in the umbrella of research where we have defined eligibility and inclusion and exclusion criteria, here you find you are able to determine the efficacy of the drug. Whereas when you start practicing using it for the community at the larger scale, then you really come to know the effectiveness of the drug. So it's very important to realize that, understand the two terms, so that when you are defining and planning your study, you are very clear about what you exactly want to do.
Absolutely. So I'm just going to read this, just to slow down a bit.
Yes, I think it's a great idea. Yeah.
No, I got a sense maybe I'm going fast because I was trying to keep up the time, but I don't want people to be lost with so much information.
No, you're doing well. Yeah.
So, okay, somebody has given a suggestion here because it's connected to outcomes. So I thought if some of you have written objective, then we could learn from that. So efficacy of carbitocin for treatment of PPH. So this is interesting since I'm not a gynecologist. Now, can somebody suggest what would be the outcome for this trial? If you are using something to control PPH, right? So what is that you will measure? Yeah.
No, actually,
Amount of blood loss.
Actually, what we wanted to achieve is whether this carbitocin, which is a long-acting variant of oxytocin, is capable of preventing. It's capable of preventing PPH. We have come to know that through the WHO trial, the Champion trial. But then the efficacy of the carbitocin for treatment of PPH has not yet been established. That is why a very good drug is being wasted. So I think that it's a very good trial if we can do a clinical trial on this. But as ICMR points out that even if it is effective in prevention, if you have to use it in treatment, you have to treat it as a new drug and go for a randomized control trial. Okay, so since again, I'm not a gynecologist, so I think that's for you all to debate. But the point I'm making here is that, okay, let's say you do this trial for PPH. How will you define the outcome? What will be your outcome? The control of PPH means... Control of PPH is very broad. So that's exactly what I'm trying to bring it down to. That whenever...
The amount of blood, I think the quantity of blood, that is one thing. The other parameter that we can take is the post-delivery hemoglobin level. I think that can also be one of the outcomes which can be measured.
Right. So I think why I'm pausing at this point is because whenever clinicians reach out to us for sample size calculation or to statistician, this is the most important question we ask. And quite often until then, they have not thought of it. So I think this is one thing you should think before you reach out for any further support, help, and so on. What outcome you want to measure? Because, if you say hemoglobin, then your sample size will be different. If you say how much blood loss is there, then your sample size will be different. Also, you have to see the literature. What is that has been reported by others? And, if you find that a particular outcome is more easier to measure than other, something may be very hard to measure, another thing may be easy to measure. So that need to be kept in mind. So, very good point made. So I think I will reinforce this. Now, again, the issue of efficacy and effectiveness. Okay, I will reiterate that. I think someone has put a point there. Efficacy is measured under strict controlled conditions in a clinical trial, wherein you are controlling everything, who gets in, who doesn't get in, what they get, then quite often during a clinical trial, you have to keep on monitoring the patient at a certain interval. It could be, in your situation, if it's during hospitalization, could be on hourly basis or weekly basis or whatever it may be, as per the protocol. But what happens in the field? Now, the same drug, when you are giving in the actual practice, let's say even in a tertiary care hospital, I know how busy the OG departments are. It is impossible to track things so meticulously, right? And then you get some results, but that result may not be as good as the result that you got in the clinical trial. And that's called effectiveness. And there are many kind of patients you might have excluded while doing the trial, but then you can't do that in practice. So you may have people who may have varying levels of sort of characteristics which dilute the effect of your drug or intervention and so on. Like in public health, we quite often talk about adherence. So for instance, you give a drug, but in a clinical trial, you are monitoring, are you taking it regularly and doing all kinds of, tracking of the patient. You don't do that in the real world. And hence people may or may not take the drug regularly and you may not see the same results. So somebody said reducing blood. I think that comment is for the previous. Yeah. So, okay, I think now this outcome point, I hope it's clear. This is very important.
Dr. Pradeep, there is one important question here. Dr. Ambuja, COVID vaccine did not have a comparison trial. There was no comparison, but it was called stage 3 trial. So why is it so? Any comment?
I think can we stick to, let's not get into COVID vaccine. COVID is a very exceptional situation, and COVID vaccine trials had very exceptional protocols. I don't think you will ever be getting into that situation. So let's talk about the common scenarios, right? Because otherwise it will take 15 minutes for us to go through that, and it will be really deviating from the topic of this.
So the point,
but I can send you a reply on that later on, maybe through email, right?
Yeah.
So so primary outcome and secondary outcome, this is very important. So you may want to measure 2-3 outcomes, but everything cannot be a primary outcome. You need to know which one will be a primary outcome and which will be a secondary outcome. So now coming to the sample size, and I know for
that example, the estimation of blood loss may be a primary outcome, and improvement in the hemoglobin can be a secondary outcome.
Right.
You were asking which outcome you would like to see. That's why I said that.
Perfect. Yeah, so that's a great example. Yeah.
Also, the need of blood transfusion or need of intensive care. These are the 2 primary outcomes, because that is the most important, I would say, because hemoglobin will be. But the primary outcome you put as the need of blood transfusion and need of intensive care. These are the 2 things.
Need of other drugs also, Dr. Shashwati, need of other oxytocin. Like if we are using carbetocin, do we need a use of other oxytocics also? That can be also added as one of the secondary.
Excellent discussion. So I think we need to move on. But the point I want to make is, which is primary will determine your sample size. I know this is usually debated. So whenever you actually come to deciding what is primary outcome, you may need to do brainstorming, and your statistician will tell you, oh, if you do this primary outcome, you need 5,000 patients. You'll be like, no, I don't want this primary outcome. You change my outcome, right? So all those things happen, there is a negotiation you do end of the day as to what outcome you can measure, how many patients, what's your budget, how much time you have. So there are many criteria that come into play. But the point I'm trying to make is, you need to know, like, what are the potential primary, secondary outcome before you reach out to a statistician for sample size calculation. So if you are having any training, basic training in research methodology, you can do the sample size calculation yourself. There are online calculators available now. OpenEpi is one that we quite often use, wherein you need to plug in certain numbers and it will give you, and then you can show it to a statistician to get a feedback. So you can use OpenEpi calculator to play around with the numbers so that you get some rough idea. So since this particular session is not on statistics, so I'm not going detail into that, but I think as far as I know, Dr. Radhika has scheduled another session on basic stats. So I think this can be covered there. But the idea is that you need to know what will be the difference in the groups. So let's say in the intervention group, let's say 20% of the patient achieved the primary outcome, and in the control group 15%, right? So the difference in the group is actually 5%. And this 5% is called the effect size. So this effect size is what you want to measure in a clinical trial. And your sample size has to be calculated to measure that effect size. And when you report your result, this is the main result you are reporting, that there is a 2% difference in the groups or 5% difference in the group. And then you also look at the statistical testing and confidence interval to say whether that is a meaningful difference at all and whether that is statistically significant. So when you're writing the sample size section, you need to mention all the assumptions which are used in the calculation. Now coming to the next most important part of a RCT, which is randomization. So randomization is a process that you need to do to make sure that the allocation into the group is not biased. So now there are, earlier we used to use paper-based random number tables, but there are online random number generators. So you can go like random.org is one. And there are many other such calculators where you can go and you can calculate the sample size. And then you need to know how you will do the randomization, who will be implementing, like you may have a research nurse doing that, or a research staff or a research assistant who will do the actual randomization process. So they will do enrollment and then they will assign people to these groups. So that process needs to be clearly laid out. And how will you do the concealment and the blinding? So next slide, which is about blinding. So blinding may not be possible, like let's say in a surgical intervention, you may not be able to do the blinding. But in certain kind of intervention, the blinding is possible, which means you can blind the providers. Ideally, you can blind all three. You can blind the providers, you can blind the participants, and you can blind the data collectors. That is an ideal situation. But sometimes you may not be able to blind all the three, but you should know whom you are blinding. Are you blinding the patient? So the patient doesn't know whether they received the new intervention or the placebo or whatever is a control intervention. For example, you may give them a medication in same kind of box or a packet. So they don't know which one they got. It will just say whatever. It should have blank labeling, right? And you may be able to blind the doctor as well. So the doctor is not told which medication, who is randomized to the intervention and control group, and ideally to the data collector. But you need to assess whether blinding is possible. Not all RCTs have blinding. Many RCTs have blinding, but there are quite a few RCTs which do not have blinding. And then you need to write about your data collection process, what kind of tools you will use, what kind of measurements, if you are doing any measurements like laboratory measurements, anthropometric measurements, who will collect this data? Are you collecting data using a paper-based system, or are you collecting a data using digital tools? Like quite often nowadays we have apps, we have laptop-based systems, and there are specialized tools available for the, I don't know if you have heard of RedCap. Like RedCap is an online system for RCTs, wherein you can capture all the data. They have excellent tools which can be customized for the RCTs. So then you need to have, very important from the ethical perspective, storage and retrieval of records. Who will be allowed to access the records? And what record they will access, and what will be the procedure for that, or who will not be allowed to access the record. For example, randomization. Who is going to maintain that secret randomization, and when will you break the randomization? So all these things need to be written clearly in the protocol. And the data entry also, if you are doing paper to digital, then you need to put system in place to ensure that it is done accurately. You can do double data entry. You can put checks and controls in making the screens to ensure that the data entry is correct. Next comes the data analysis section. And here you will talk about your effect size. Like what is that you are going to measure, your outcome. We will be looking at difference between two groups for this particular outcome. And currently it is the best practice that every outcome has to be presented with the 95% confidence interval. So nowadays most journals insist on that you have to present 95%. You can't just give the percentage, you have to give the CIs, and you need to have an analysis plan for primary and for the secondary outcomes. And if you have subgroups, you also need to say, I will analyze the data by these subgroups. And so I will not go too much into analysis, but the intention to treat analysis is one of the best practices in analysis, wherein you analyze the group as they were randomized, even if later on some changes took place. You can do quality assurance at all levels. So basically for RCT, you need to follow the GCP guidelines, which is good clinical practice guidelines. And they clearly mention what kind of quality assurance you need to do at all levels, starting from protocol writing, collection, entry, analysis, and reporting. You can also follow a consort statement. So there's a website consort statement that has for each section, whatever I have to talk today, for each section, detailed explanation is given as to what need to be there in each of the sections. It goes up to presentation of results, and there are flow charts, how you present your data and so on. So I'll not go into this, but for the completion's sake, I'm just mentioning that you need to have a section on human participant protection. So this section should mention all these. And I just want to add on one more thing which is not written here is now there is also guidelines on insurance. I think for clinical intervention, you need to also, patient need to be insured. Some kind of insurance need to be provided to cover for any adverse events. And you need to make sure that your ethics committee is accredited. Not all ethics committee can approve clinical trials. So there are certain guidelines. I think medical colleges, it's not an issue. But if you're in the private institution, you need to make sure that your ethics committee actually has the accreditation to approve clinical trial. So we are going to stop with this now. So I'm moving to the second part of my talk, which was to sort of walk you through an example. Should I take any questions at this point? Anything on the chat box?
No, actually, I think you can move ahead, but then I mean, in the end, we can discuss about the, human, safety analysis and that part, because that is the most important deterrent nowadays for conducting the clinical trials, I believe. And this is the reason why we cannot conduct the randomized control trials or clinical trials in the PG students these days.
Okay, all right.
And please also provide that those you have said something consort some for that.
Yeah, I think I'll
want to do quality assurance, which and you post in the chat box, for the postgraduates and random table,
I think I'll put that link in the chat box for you. Okay, so I think we'll move on. So as suggested by Dr. Radhika, I thought I will use an example from an OG RCT. So first of all, forgive me because I don't understand a lot about the technical aspect of as such OG. So what I will be focusing only on the methods in this. So this was a very interesting study, and why I picked this up was this is an Indian study. So it is done by AFMC, and it's a trial to, so I've mentioned the reference at the bottom, as you can see here. It's a randomized controlled trial to compare, to compare injection ferric carboxymaltose, I don't know what it is, and oral iron in reducing postpartum anemia. So it's a multi-centric study. So this, to me, it seemed like a very, very nicely done, very simple trial, which was done in Indian setting. So it tells you it's feasible, right? And this was done in 2 centers. So what I did, based on some of the subheadings that we talked about, you can, this is, I think, a free article you can download and read. I can also, actually, Dr. Radhika shared this article with me. So I think maybe she can post the link or email to the participants. A very beautiful RCT. It's done with, very reasonable methods. So they compared, as you can see here, there are two things which are being compared, right? So it's a multi-center. So in the study design, they clearly mention it is a multi-center, It is randomized. It is carried as pilot study for a period of 1 year. And they did it in 2 tertiary care centers. Now, coming to the participants, there were 800 women who were to be studied. That was the sample size. And that was divided in 2 groups. So they did it 400, 400. And in each center, they had 200 women in the intervention group and 200 women in the control group. They have nicely written about their inclusion criteria. So it talked about all the women delivering at term, which is 37 to 42 weeks of gestation, and who were diagnosed with anemia after delivery, which is hemoglobin less than 11. So this is what I was talking about, what endpoint you want and how you are going to measure it. And exclusion also was very well defined. So hemoglobin more than 11 or hemoglobin less than 7. And then all these other criteria were nicely mentioned. So this is important. So they talked about how they did the randomization. So they did the computer-based randomization, and they put the patients in 2 groups. So group A was given ferrous sulfate, 1 tablet daily for 6 weeks. And they were told to take this tablet before meals and to avoid all these things. And group B was given the IV medication with the normal saline over 15 minutes. And the outcome, so this is what we were talking about, right? What is that you want to measure? So they measured hemoglobin levels and they measured serum ferritin at 6 weeks after delivery. And the secondary outcome, so the primary outcome is hemoglobin and ferritin, right? The secondary outcome is they looked at compliance, and they also looked at the side effects. So if you go through this particular trial, I mean, you can go through the analysis and the results section, but I think this can be a good example which you could use as to how to write the protocol for a trial. So I'm just going to stop here for a minute and, let's discuss a little bit about the structure of, let's focus on that. I think this is the most important thing that many of you are involved in writing protocols. So do you have any question about structure of a RCT protocol or any comments? Since there are many experienced investigators here, would you like to add something which I might have missed, which is relevant? Any comment?
One question, Dr. Prabdeep, like this is a pilot study, it is a multicentric pilot study, it's an RCT. So should it be registered as a clinical trial?
Yes, it should be registered. Yes. Yes. So all the clinical trials should be registered. You're right.
Which is on CTRI for India, and it has to be done prospectively. They don't take retrospective studies.
Yeah.
Dr. Pradeep, could you also focus on the randomization for surgical procedures?
Actually, to tell you the truth, I don't have much experience with that. So actually, I'd love to hear from you people if there is anybody here who have
because it becomes kind of challenging because it's not possible to.
Okay, what you're talking about is the randomization.
Should not be a problem. I'm talking about blinding. Yeah.
Okay. Randomization is same because you are going to pick the random number sequence. Blinding, I'm not sure it is possible, but if there is any experience, because I don't come from that background,
that's fine.
I'm not sure how the blinding can be done for a surgical
I think single blinding can be done if both the procedures are comparable. Then I think single blinding can be done, but not double blinding, because the surgeon will know which operation he's going to do on which patient. Single blinding can be done.
Can hear from others, because I would really express my ignorance on this.
There are 1 or 2 questions here. Can we take them also up? Because
sure.
Because this is something which everybody, many of the people in private practice, they face that. Dr. Runa would like to know in private setup, how to have it in the private setup, how to do that.
Yes. So I think you can read the, it's a good question, that how do you go about ethical approval in a private sector? So currently there are guidelines as to, I think, what kind of facilities you need to have and what kind of criteria you need to satisfy for your ethics committee to be approved by the by the government. And I know my previous speaker may actually have a better idea on this. What does it take to get your ethics committee? Because in government, it's not an issue. And
but the government ethical committee also, they take within a radius of 10 kilometers. If anybody is interested to do some trial, they can go to that particular ethical committee of that institute, medical college, and they will definitely anywhere where there is institute there. I mean, they can give your drug trial. They can allow you drug trial. So that ethical committee, they have the, I mean, they can give there the consent, allow them to go for that trial.
Okay, I was not aware of that. So if
it is there, because in our college we take at least within a radius of 10 kilometers, any hospital, private hospital, if they're interested to do some kind of trial, they can always come to us.
Yeah, the government also tags certain teaching institutions with the private hospitals if they're interested. In fact, they open some applications every year for opening up of the research programs from private hospitals, and they tag certain teaching institutions and institutions with that particular hospital. That is possible.
Okay, I think that's.
I also have a small comment on this. So it's important for people to allocate some amount for institutional fee. You know what happens is they want an ethics approval, but there is nothing that the institution is receiving from the researcher. And IEC finds it difficult there. It's always a good idea to allocate some amount of, there is a certain percentage as per the ICMR guidelines. So please remember to put
for
that.
Drug trial, we have our ethical committee, we have decided that you have to pay this much of like 1 lakh. If it is for drug trial and company driven, the company sometimes they give the centers, even though ICMR, for us, because you have to go through a lot of issues and all these things. So our the ethical committee, they have said for any drug trial, which is companies providing, because we have all the super specialty department, they do a lot of interventions especially in the hematology department for the cancers and all. So for that, we ask them for 1 lakh. So for in that kind of trial, you need to pay a little more.
Okay. I think there's another question on how to take ethical approval for a new drug on vulnerable group like pregnant women. So as far as I understand that, if that particular, so most of the time, this drug might have been used in another country, or it would have anyway gone through phase 1 and phase 2, right? So unless it is found safe, it will not come to phase 3. So when you have come to phase 3 trial, it means you have already established the safety of the drug. So that should not be the reason for DCGI not to approve the trial. Now, certain intervention, as you know, even COVID vaccine, pregnant women were not included. So wherever there is a doubt and it's not known whether this intervention is safe for pregnant women or not, then DCGI may not approve. But if it's an intervention meant for pregnant women, it would have gone through the safety already. It would have already undergone in the phase 1 and phase 2. Phase 2, it would have been established. So that is to answer this question. Do we need to take approval from DCGI before ethical approval? So for any drug to be available in India, you have to have DCGI approval. So only after the drug is made available. And ethics committee role is different from the DCGI role. I think we should not mix the two. The DCGI is regulatory on the drug side, whereas the ethics committee is looking at the human subject protection. They are looking at the human side of the trial, whereas the DCGI is looking from the drug regulatory perspective, and they play very different roles. And is there anything else? I think I've answered. There's somebody has answered this, that in surgical cases, it's open label trial. It means that you may not be able to do the blinding, or I don't know if there are any innovative ways to do the blinding. At least I'm not aware of that.
As it is, the blinding is not very, it's not a mandatory thing for the
RCT. Yes.
Yeah.
Yeah, blinding is not mandatory. In fact, large number of, see, when we look at, for instance, many of these community trials, most of them blinding is not there, especially in public health side. We do a lot of community-based trials, and there blinding is mostly not possible.
Can I have a comment on this? Because as it is told in surgical procedures, some of the outcome actually, I have conducted a couple of studies like in this way. Suppose for a cesarean section, the two suture materials we used for closing the subcuticular suture. So in those situations, one is which method will go. So that is when the one blinding the patient which will read. So it is possible to blind the patient also, but the surgeons cannot be blind. But if you would like to assess the outcome, so your outcome assessor can be done who is blind on that situation. So in those situations, some surgical procedure outcomes, so it can be a double blind procedure in some time, where your surgeons will not be blind, but the person who is assessing the outcome or various outcome, that observer, who you can say who will be recording, that he or she can be blind, and that way some of the surgical procedure can be made double.
Excellent. Yeah, excellent comment. See, I'm learning so much today from all of you. So this is the advantage of interacting with people from other specialities. We learn new things. So I think I'll move to the last part. I hope I'm keeping the time, Dr. Radhika.
Yeah,
yeah,
perfect.
okay.
Yes.
Yeah. Okay. So we'll move to the last part, and this is the one I was really looking forward. This is about like from research question to study design. Actually, my current Director General, Dr. Ajib Bell, he was recently talking to us, and he said he was a director of maternal child health research at WHO and moved to India in October. So he told us that in his experience, he felt this is the most important thing which should be taught. Understanding the research question to objective and the objective to choosing the right study design. His point was, if you get this right, then you get everything else right. So I think this is really important, and I try to pick some questions. So I did a bit of a homework, and I spoke to some of my colleagues who support OG thesis and studies in the medical colleges, and Dr. Radhika also sent me some suggestions. So I have put here 5 such topics. So I think we'll spend little time, and I really request participants to, use the chat box to take the discussion forward. So let's focus on the first one. So the first topic is pregnancy outcomes after laparoscopic treatment of endometriosis. So they wanted to study, so they're doing the laparoscopic treatment of endometriosis, and they wanted to see the women who underwent that, how were the pregnancy outcomes? So anybody want to put it in the chat box? If you can go back to my first slide, I told you there are observational studies and there are interventional studies. So observational studies can be, again, descriptive or analytical. Descriptive is cross-sectional, analytical is case control and cohort, and intervention is RCT. So let's keep these 4 designs in our mind, right? So of these 4 study designs, which one you think is suitable for this? This is more for discussion. So I would request everyone to participate in this. You can either put in the chat box or you can raise your hand if you want to talk.
Yeah, incidentally, people can raise their hands and even unmute and speak. So
sure.
It'll
be nice if people can talk, because that will generate discussion. Or you can put in the, okay, somebody said observational. So that sounds good. So within observational, you have cross-sectional, case control, and cohort study. Any idea as to which type of study you would like to do for this particular question? I think we'll give some time for people to respond to this. Okay, somebody said cohort, and somebody said cross-sectional. I would like to hear those who said, somebody said cross-sectional. Why do you think cross-sectional? And then we will ask those who said
unmute themselves.
Can you tell us why is it cross-sectional? Why do you think it's okay? You need to unmute the participant. I think they're not allowed.
Yes, ma'am. I have to unmute them.
Yeah. So you can unmute Nivedita.
You can raise your hand, please, and there is somebody at the back end who will unmute.
Okay. Yes, ma'am. Yes. Nivedita is unmuted.
Nivedita, would you like to tell us why do you think It should be cross-section. Can we hear from you?
Nivedita, are you there? Dr. Sudesh, I have unmuted you. Please.
Dr.
I can't hear. Okay. Okay. Somebody.
She is also unmuted, ma'am. Dr. Sudesh Agrawal is also unmuted.
Okay. Thank you. Thank you for unmuting me. What I want to put is that both the things are possible. Suppose we are doing cross-sectional study. That means we will take a sample of the patients who are delivering, then go retrospectively and then take the histories, whether at some time they had some laparoscopic treatment for the endometriosis. But my option will be that I would like to do the cohort studies if in my OPD or if I am having some patients whom I have included, they had the treatment for endometriosis, then I would like to see over next few years, when do they conceive and when do they deliver? That is my submission is.
Excellent, Dr. Sudesh. You have made very good point. I really wanted to hear somebody who said cross-sectional, why they said so. Okay, so let's put it the other way around. What is the disadvantage of doing a cross-sectional survey? So you know the chicken and egg story in a cross-sectional survey, right?
The temporal outcome cannot be established.
Absolutely. So we cannot establish whether this led to this, whether the two are connected, right? So that is a disadvantage. So since you are trying to look at a pregnancy outcome, ideally you should do a cohort study here. So you take a woman and then follow them over a period of time. And that is going to give you a much more accurate information. You can, as Dr. Sudesh said, you can do a cross-sectional survey. You can ask women questions and try to get a history, but that's not the ideal study design here. So let's move on to the second topic. So this is about reproductive outcomes after laparoscopic myomectomy. So the investigator here tried two kinds of sutures. Well, I really don't know what they are. Conventional versus barbed suture. So can you put in the chat box?
RCT.
Okay, let's hear from others. Anybody has any other view to this? Anybody would like to comment how this RCT can be designed? Any volunteers? How would you design this RCT? Just tell maybe one or two. Yes, Dr. Sudesh, I think you would like to.
Okay, ma'am. Again,
yes,
this will be possible with the cohort study if we are really doing it. Though it is going to be time and the resource consuming very much. First, we are doing the surgeries. We are keeping certain records. That records, we can keep it blinded. But these patients, to find them, and then we have to follow them up for quite many years. When do they get pregnant? And what is the finally outcome? Are they going to deliver normally? Do they require cesarean section? Are there any suture problems or something? That is how we can do, or what is the baby outcome. So I believe ideally that should be the cohort study, though it is going to be a bit difficult one, not an easy one.
Okay, I got your point.
Multi-centric, that is the only option. That is how we can get all the necessary patients for such studies.
Okay. So basically RCT is also a cohort, right? So that's the point I wanted to make. So RCT is a cohort study. The only difference, so what's the difference between a cohort and a RCT is in RCT, you are manipulating, you are doing something different. Whereas in a cohort, you are not doing anything different. So the issue is if you are all doing only one kind of suture in your practice, then the cohort study will not answer your question because most people would have only had one type of suture, whatever conventional suture, right? So that's the problem with the cohort study here. You will not be able to compare the groups. because I don't know, unless some practitioners do BARB and some practitioners do conventional, and this is happening routinely in the practice. So since I'm not aware about the field, so I'm not able to come to that conclusion. But if it is routine thing that some people use this, some people use that, then you could do a cohort study. But
the point is, then the matching and the pairing may not be there.
Yeah,
if you really want to compare the two groups.
Yeah, exactly.
So I think it would be a good idea to start with an RCT.
RCT, if it is something like you really want to know whether this intervention is better. But I think Dr. Sudesh pointed out. So then comes a question of feasibility. Is it practical? How long will it take for you to find the answers? But just to answer that question to you, that's not a reason not to do it. Right. So if you look at, a lot of the answers, I'll give an example that you all may be familiar with. That is hormonal replacement therapy and the risk of cancers. That study was done for decades, right? In US, it's a very large cohort study which established that. And following which there were a lot of change in the HRT prescriptions and so on. So it may be difficult, and maybe it requires that that's when you need to do multi-site, maybe you need to have many more centers. So in general, my suggestion to you all is that do more collaborations, work in bigger teams. So if you look internationally, now the trend is to actually have big collaborative study than doing small studies in your own centers. But somehow in India, we feel like my study. So doing multi-investigator large studies, you are more likely to answer your questions than doing your small little studies, although you have more control over it, but it's not good for the science. If you do multi-site large study, that is good for the science and also for the patient care and practice, right? So the sample size will need to be calculated based on, yes, effect size. And the multi-site studies, yes. In the multi-site studies, the sample size is calculated and then distributed across the sites. So for example, if you need to recruit 2,000, you don't have to recruit 2,000 just here. You can distribute it across multiple sites. Okay, so let's move on to the third one, which is again, detection rate and diagnostic accuracy of sentinel node biopsy in early stage endometrial cancer. This is the actual thesis from a medical college. So I'm not imagining. Yeah. So any suggestion? What do you think? What kind of cross-sectional? Anybody want to comment? Anybody else? I would like more people to talk. Same people are talking again and again.
Okay, so if I say that it is a cohort of ladies in early stage endometrial cancer, and we wish to see the diagnostic rate and diagnostic accuracy of sentinel node biopsy.
Okay.
So if I say cohort, how many would agree with me? And if somebody says RCT, why?
Biopsy one intervention is taken.
It can only be randomized. Ma'am, Dr. Ambuja, ma'am, you can be unmuted. Probably you can also, share your thoughts. Why it has to be, it has to be only randomized.
Yeah, Radhika,
yeah.
I just want to comment on the previous one first and then go to the other one.
Right.
The reproductive outcome of laparoscopic pyomectomy, conventional versus barbed suture, it can be only observational study. Why means you cannot dictate a surgeon, you have to do this or that, and you cannot blind the patient also. And how many cases you get to do the things? Myoma cases will not be in hundreds, it's only in numbers, single numbers or double numbers, it will not be there much. So do you call that as a cohort study?
Ma'am, here is a situation. Number one, you said the surgeon may not be interested, then he is not the right person to participate in the study. We need to have a group of people who share the same thought.
Conventional, anybody will, conventional, they do it. And barbed sutures also they do it. Then it is only observational, what they are doing.
So that's what we talk.
I think other centers, right? you can combine with other centers.
Exactly. You
Participate.
can pool data from multiple center and do a cohort study. If many, that's what I said.
20.
Yeah.
You may be doing 20, but you can combine with 50 other centers to make
Even
it.
then, it is not in hundreds of thousands.
No, you can
Yes,
How
calculate
many
the sample size.
myomectomies they will have, and how many myomectomy patients will go in for pregnancy? See, you may do myomectomy, but not all for infertility, but so many other reasons. That's the way you will not get so many numbers as to say it is a cohort study or anything like that.
But you select out
Yeah.
patients who are suffering from infertility. In a subgroup of these patients, you can select out these patients.
No, it's only maybe my ignorance, just to sort it out. I'm asking. I may not be.
No, ma'am, it's a challenging study, all right.
But still,
yeah, certainly point well taken. Actually, we are also nearing the closure time.
Yeah.
So we need to.
So we'll go a little
also,
quick. Yes,
yeah.
we'll go a little quick.
Yeah.
So I think the third one is a cross-sectional study. You can do it as a cross-sectional survey because it's basically you are looking at diagnostic accuracy of a particular type of, test here. So your sample size calculation will depend on, how, what do you think is the sensitivity, specificity, and so on. I'll not get into detail of that, but the thing is that this can be done as a cross-sectional survey. So the next one is effect of dosage schedule of mifepristone on size of myoma. Any quick comments?
RCT.
What type of
RCT.
study would it? RCT.
Yeah,
Okay, we're all in RCT mode. So this sounds like a good one for RCT, wherein you can use 2 dosage schedules in arm 1, arm 2, and then you can compare your outcomes. The last one is factors associated with low birth weight.
Observational.
Any other suggestions on that? Factors associated with low birth weight.
It can be a case control study as well.
Excellent. Any comments from others? So what's the best study design, cross-sectional or case control? I think most people
Case control.
Yeah. So just to summarize, what I want to say is when you want to estimate a quantity, then you do, like in epidemiology, we say that, when you are saying measuring something, that's when you do a cross-sectional survey. And when you are trying to test a hypothesis, right? When you're testing a hypothesis or when you're trying to determine something, that's when you do an analytical study, which could either be a case control or a cohort study. In this setting, I think case control study is easy to do simply because easily you will get babies with low birth weight, and you can also find the control group. So I think I'll stop with this. I hope this was the objective of this session, trying to make people think through. So I think this is most important. I would really encourage you all that you spend a lot of time with, your students and brainstorming. Just ask them to generate questions. So rather than thinking about, I find quite often medical college interaction, people come to us and say, I'm collecting this data. No, data comes much later. So they should think through the question, objective, and design, and that determines everything else thereafter. So thank you very much for the opportunity, and over to the chairs of the session. Thank you.
Thank you, Dr. Prabdeep. Indeed, it was an excellent session, such an interactive session. And I think you have, with your lectures, I have also seen your videos on the basic biomedical research, and you're really doing a very good job. I think now it is mandatory for all medical faculties as well as postgraduate students also to go for the basic biomedical research. And explaining it so well, I think more and more people will now understand research. So very nicely explained. RCT, we all know that it is the best form of the research, the golden criteria for doing a scientific research, the gold criteria, and also it has the greatest translational value. That is, if we are trying to know the effectiveness of a drug, or we are trying any new treatment, I think RCT is the answer. So thank you so much. I think you have explained everything so well. The chairpersons have nothing to say, but definitely I'll call Dr. Ashish Mukhopadhyay to give his expert comments. Sir, please.
I feel humbled to give any expert comment on this lecture. Dr. Prabdeep, you have been excellent. I mean, I have been attending, this is perhaps my 100th workshop on research methodology, but I was really overwhelmed by the method. I mean, the technique that you have adopted is very, very good. At this young age, you have developed this unique teaching technique, which is very, very good, I believe, for all of us, including our postgraduates. So I will adopt this model. And I think there are a lot of things that you have discussed, but in a very simplistic way. That's the key element of your lecture. And I was really, really influenced by the kind of delivery that you have done. And I think with the confidence that you have given the lecture, that is also outstanding. So I'd rather appreciate with a big round of applause for you. And I think that this will be really, really useful for all our postgraduates. Our most important target is the postgraduates, because we cannot attract them towards the research methodology. That's the chief. And two of the important bottlenecks I have already told you. One is this, our PGs, they are not interested in research methodology. And secondly, the human compensation, which I raised this issue in the, randomized control trial. That's a major deterrent. Anything that we can do about this will be highly beneficial for the interest of, research. And I think ICOG, Foxy could open some talks with ICMR and Government of India about this. I know that there is no relaxation is possible on this ground of, compensation ground, but that actually compensation ground actually invites the inclusion of a third party or an agent or a donor, which actually complicates the issue, and then everything follows. So I would like to take it as last your comment on this. I can take the comment of Dr. Radhika also, or even Dr. Lakshmi Shikhande, our chairperson. This is the two important issues which is always lurking in my mind while I'm doing the PG teaching. So I just wanted to have a discussion on that. Thank you very much for your excellent lecture.
Thank you so much, sir.
So I think that's two very important, valid, practical points. In fact, I was the participating, in fact, I was a site PI for the FESPOST trial, which was WHO MOHFW trial, which compared iron sucrose, basically the use of iron sucrose because policy decisions were to be made, and getting this agent and the insurance. Correct. And going through DCGI was such a big problem.
Hell of a job. Yes.
It is a fabulous problem, and it becomes almost like a deterrent for one to undertake a drug trial. But then, because there are so many safety issues involved, I think it is a good idea to have a big team. Having a person with experience in the team is extremely important. And of course, the agencies have also got to make it user friendly. They want everything to be done online. Even a single morbidity or a mortality is viewed with great concern and suspicion. So I think to that extent, the agencies have to loosen up also a little. And while we in India have to be careful with our patients, the first speaker talked about, we feel that they are not educated and they may not be able to take a decision. So I think we need to change that view, the idea that majority of us think they are very intelligent and we need to make them participatory. So Dr. Lakshmi, please.
Dr. Radhika, yeah. I just wanted to highlight this issue in a different way, because you see, it's not about questioning about the intelligence or education, etc. Yeah, the question is, the postgraduate training, postgraduate research has been reduced to always an observational study or a very ordinary kind of studies, and they can never elevate themselves to this kind of level because of this issue. That is my main concern is, every time we assign our thesis to a postgraduate student, it has to be like this, always bound by this. Why can't they conduct a randomized control trial? That is this thing. And also the time is an important issue.
Absolutely.
Postgraduate time, postgraduate time is only 1 year. Total time is only 1 year for study time. That is also determined. So we need to do something to hold hands of the postgraduates. If we really want to elevate or uplift the level of the research by the postgraduates, we need to really, and all should come together, like Foxy, ICOG, like the donors, like the Government of India, like us, the teachers. Everyone should come forward. If you have really,
I would also like to add one more point. The postgraduates have to be not only taught the primary research, they should also know about the secondary research.
Correct.
Probably now in our country, we have such a lot of data available, but we are unable to collate them. So many times we end up duplicating that work. So
Right.
it is extremely important to know about the secondary data, how the so now this is also an opportunity for us to advertise the fact that we plan to hold a session in the month of March or April on systematic reviews, how to conduct the methodology and everything else. So please do join us. So Dr. Lakshmi, please.
So I was just listening, and Pragya and Prabdeep have done an excellent job, and Radhika, full credit to you to search them, find them, and give them that topic where they can really do justice. And their way of teaching and involving audience was most appreciable thing is that, because it is such a boring topic when we talk of research, and if the speaker just goes on saying, audience, they really disconnect. But these both speakers, they had that knack of involving the audience, which was too good. And Ashish, your comments, I have really noted down. I mean, let me see what I can do at ICOG level, but they are worth considering. So I will try my level best to have some action on your suggestions.
If you remember, Dr. Lakshmi, we had right at the beginning when we were planning these sessions, we had decided that it will be interactive. So I kind of literally gave these, forced the initial speaker, Dr. Archana, and she really took it up well. And of course, Dr. Pradeep is a seasoned speaker. So,
and Dr. Radhika, congratulations on double issues, because you have been the find of our ICOG chairperson, and also if the ICOG chairperson says that it's a boring session, then what my PG will say from now onwards.
No, flattery, Ashish. She's really doing a fantastic job. The first session was also too good. The topic and the speakers, I mean, they did full justice. And today also you
both the sessions.
Hats off to Radhika. And I'm sure after 1 year of my tenure, at least I will be able to contribute something towards this much neglected field.
Correct.
That is research.
Available on, will be available in the Foxy website or something, the recorded thing?
Saraswati, we will upload it on ICOG website.
Great. Because I think with this PG, they should be, they're able to attend, because the excellent point, both Dr. Pragya and Dr. Pravdi, they have given so nicely the how to write that RCT. It's really appreciable.
So I'm very happy that you all find research interesting. I think that's my job done, getting more and more people into the world of research. Like in India, the thing is, we have actually a lot more patient population and type of disease and everything available to us, but we are not tapping that resource. Especially in medical schools, we have large number of everything. Like you are worrying about numbers, and I was thinking, like, why are you worrying about numbers? If we can't get numbers in India, then where else are you going to get it? I think it's a mindset. And if you find research exciting, you find ways to do it. But most importantly, I want to reiterate the point again. I think why people find research boring is because we don't talk enough about it. Like we don't talk the exciting part of it, right? When you find answers and when you share that with your peer, with your, or you improve patient care, that will make you happy. So I think this is my suggestion that, if the Foxy can help connect the specialists across various organizations who want to do research, then you might be able to create this community. And because you need to do a lot of brainstorming and discussion, like what we did today a little bit, and then it will become interesting. I think when you're doing it in isolation, it's boring and it can be very exhausting, and you need to connect with some organization like ours and others where people can give a little bit of this push from the methodology side, data analysis side, so you don't feel stuck there. And in fact, as Foxy, you could think of having a panel of, statistician or epidemiologists who are willing to offer this assistance. So you could channelize it then to those people.
Great idea.
There is another way which I will tell you, which I'll tell you only when the recording is off.
I think Dr. Ranjana can go ahead and give the vote of thanks, and then we can switch off the recording.
Okay, ma'am. Yes. Actually, Dr. Vaishali had to give the vote of thanks, but I think she is not well. She is here, but she has given me this task. So it is said, develop a passion for learning. If you do, you will never cease to grow. So it is It is my heartfelt thanks to Foxy President Dr. Rishikesh Pai sir and ICOG Chair Dr. Lakshmi Shikhande ma'am for their visionary initiative of this research methodology webinar series. I am extremely thankful to Dr. Parag Biniwale sir, Vice Chair ICOG, for his active participation and presence throughout today's program. I am really thankful to Secretary General Dr. Madhuri Patel, Foxy Secretary General, and Secretary ICOG Dr. Ashok Kumar sir, Editor-in-Chief Jogi Dr. Geeta Balsarkar ma'am, and Editor Emeritus Dr. Suvarna Khadalkar ma'am for guiding us. My most sincere gratitude and thanks to AG Radhika ma'am. Working with her is a real pleasure as she is a very methodical and meticulous organizer. My heartfelt thanks to our esteemed chairpersons, Dr. Meena Samant, Dr. Hafizur Rahman, Dr. Archana Kumari, Dr. Saswati Sanyal Chaudhary, Dr. Abha Rani Sinha, and Dr. Ashish Mukhopadhyay sir for their brilliant discussion throughout the event today. And my most sincere thanks to our wonderful speakers, Dr. Pragya Kumar and Dr. Prabhadeep Kaur. We have really learned a lot from both of you. Finally, my heartfelt thanks to all the participants, that is attendees of today's webinar. Your presence really energizes us and again gives us energy for our next event. And thank you, Dr. Vaishali, my co-coordinator, for being present despite bad health. And at last, a big thanks to Nilima and Jignesh from ICOG office, who really work hard in organizing this webinar series. Thank you, everyone. Thank you very much.
Thank you.
Thanks for the opportunity. Thank you.
Thank you so much.
Komal?
Yes, ma'am.
Ashish, but what you were talking about the PG ka thing, na, but teachers also there, we have to change their mind.